Yes.
I just have a handful of questions from others. In your non-obstetric work, which other specialties did you have much interaction with?
Gynecology, ear, nose and throat surgery, and earlier in my career, plastic surgery.
Did you notice any variations in the approaches that different clinicians or different specialities took to blood transfusion?
And no, but as I said, it was quite. In fact, I don't think I ever used blood transfusion in my ENT or plastic surgery work. Occasionally in gynecology, but of course I was working essentially with the same specialists as I was working with in the obstetric field then.
And more broadly, as the clinical director of anaesthesia, were you aware of any colleagues indicating that there was a different approach across different medical specialities, surgical specialities, I should say?
No, not in my hospital anyway. So.
When we spoke about estimating blood loss, did the awareness of the tendency to underestimate blood loss lead to an increase in blood use as more accurate estimates of blood loss developed?
That's a very insightful question, actually. I think certainly in the early days we tended to underestimate blood loss, and so our patients remained unstable after we'd replaced what we thought had been the estimated blood loss, and we ended up having to top up with further blood to bring the patient back to a state of stability. I think there has been something of a rebound effect, and I have encountered within my own hospital and perhaps more frequently within my medico-legal practice patients who have been over-transfused. And over-transfusion is a recognised phenomenon which itself can lead to significant morbidity and mortality.
So those are the questions I had for Dr. Bogod. Do you have anything you'd like to raise?
No, I don't. I think they've all been answered.
Dr. Bogod, is there anything else you'd like to say?
If I could take the opportunity, I'd just like to say that my reading in preparation for this hearing has given me considerable cause to reflect. And I'll certainly, when the inquiry reports, I will undertake. I know you'll obviously say you'll be reporting to the relevant specialist bodies anyway, but I will undertake to pursue, from my angle, actions by the appropriate professional bodies in anaesthesia. I think even if a complication is rare, and even if the risk-benefit analysis of a treatment falls on the side of benefit, that in no way mitigates the human tragedy which has prompted this inquiry. And I would like to offer my heartfelt sympathies to all who have suffered, and my sincere condolences to those who have lost loved ones.
Sir.
Well, thank you for that. The report, it has to go to the Minister, whoever the Minister then is, who is responsible for the inquiry, Minister for the Cabinet Office, often the Chancellor of the Duchy of Lancaster. And it then is published to Parliament in whatever form I write it. But thank you for that assurance at any rate. It's very welcome, as indeed has been your evidence in the direct and thoughtful way you've given it. I very much appreciate that, and you understand, I think, from the questions you've been asked and your thinking about what you've read and listening to some of Professor Steer, quite how important it is to get a full picture.
Indeed, I do.
So thank you.
Thank you.
Thank you. So tomorrow we hear from Dr. Wallace and Professor Murphy.
10 o'clock. 10 o'clock tomorrow.
Thank you.